Good evening, everybody. First of all, I would like to thank Dr. Kutulas for his kind invitation to present the humanitarian pediatric cardiology and cardiac surgery in low and middle income countries. Thank you very much, Dr. Krupali, for being online with us and for your comments after my presentation. Now let me start with the definition of low-income country. As you see here, there is a very, I will say, efficient index defining the low-income countries, which is the Human Development Composite Index related to the life expectancy, educational level, and also to the economic power or quality of life of a given country. If you see the map of the world, only 20% of the world global population live in countries with HDI superior to 0.7. It means the rich countries, the developed world. 30% of the population live in borderline countries with middle income, and the HDI index is between 0.5 and 0.7. And as you see, 50%, the remaining 50% of the population live in countries with HDI index inferior to 0.5, which is the definition of the low income. Compared to the more developed countries, in less developed countries, you see the demography of the population. There is more young people who are more, I will say, vulnerable in terms of diseases. And in the more developed countries, as you see, the distribution of the demography has the shape of an ellipsoidal shape. There is a homogeneous distribution between male and female and between young and middle-aged and elderly people. There is another factor regarding the world population, especially regarding the people less than 18 years old. As you see here, more than 50% of the population are made of young people, less than 18 years in these countries represented by orange color. And 85% of this young population live in low-income countries, which represent around 2 billion children. Now, as you know, there is some indicators which is in relationship, close relationship with the health condition. And in low-income countries, despite all the efforts and all the money invested for the improvement of the conditions, there is, I will say, a very small improvement regarding the life expectancy at birth between 2000 and 2010. As you see, again, there is a small decrease in infant mortality, a small decrease in mortality under 5, and also an increase in measles immunization. It means things that are not going as we are expecting. There is also some parameters to determine the needs in cardiac surgery. As you see, these 3 parameters are very important, especially the first one is the number of open heart surgery cases per million of inhabitants per year. The second parameter is the number of cardiac centers per million of inhabitants. And the third one, the number of cardiac surgeons per 100,000 inhabitants. Let me start with the first one. If really you would like to cover all the needs in terms of open heart interventions, the country has to be able to perform 860 cases per million inhabitants per year. If you have, this cutoff value, and if you see a little bit the distribution of open heart interventions, the best results belong to North America with 1,222 open heart interventions per million inhabitants per year. Then Australia, then Europe with around 600 cases per million inhabitants per year. And then if you go to South America, the results are getting worse with 147, Russia 37, Asia 25, and unfortunately the final position belongs to Africa with 18 cases per million inhabitants per year. Regarding the second parameter, the needs in terms of cardiac center, again, the best situation is in United States with one specific center per 120,000 inhabitants. In Europe and Australia, there is one center per 1 million inhabitants. In Asia, one center per 16 million. Again, the final position belongs to Africa with one center per 33 million inhabitants. It means that 4.5 billion of people have no access to cardiac surgery outside of North America, Europe, and Australia. Regarding the last parameter, the number of surgeons per 100,000 population worldwide, again, the best numbers are from United States, 51 cardiac surgeons per 100,000 inhabitants, then Japan, Canada, Australia, Germany 13, China 10, and then in Latin America 7, and if you go again to Africa, this number is going down. Now, one of the other additional problems the low-income countries are affording is the brain drainage, and especially I was in 2007 in a regional, I was attending a regional conference in Nairobi, and there was a lot of cardiac surgeons and cardiologists, and I asked this question, why, they would like to leave their country. And among this 100 surgeons, only 21 have the courage to reply to my question. And as you see, 38% of this respondents wanted, to leave the country. And if you go and investigate a little bit the reasons, in 65%, it was due to financial conditions of the country. 24%, they wanted to have more training facilities. 1% political, and 1% was not satisfied by the job. What is now the situation? I'm mentioning this one, the brain drain, because is a real problem, especially in the low-income countries where there is no highly qualified medical and paramedical human resources. As you see, approximately 10% of physicians in high-income countries come from low-income countries. And especially for some African countries where our foundation has humanitarian missions, we realize that this equals 30% of their health workforce. 60,000 professionals, medical professionals, emigrated from Africa between 85 and 90. and there is 20,000 professionals immigrated since then. Again, if you see a little bit the statistics of United States, you will see that there is 21,000 Nigerian doctors, and 60%. The situation in Ghana is really very dramatical, because 60% of the Ghanaian doctors trained since 1980 have left the country. As I told, the brain drain has a cost for low-income countries, but benefit from high-income countries. For example, in UK, they estimated that they saved 120 million pounds in training costs between 1998 and 2005 by recruiting only Ghanaian health workers. Again, there is another report published by the United States Congressional Research Service between 71 and 72. And for each professional medical migrant, the United States gained 20,000 per year dollars. In the United Nations Conference on Trade and Development in 1979, there was a very nice presentation and making an estimation regarding the cash value of an African medical professional migrant, and this one, this value represents $184,000. Unfortunately, this one, as you see, all these numbers can easily show what the low-income countries, which have restricted human resources, they are losing on a yearly basis. Now, regarding the current situation in low-income countries with regard to cardiac diseases, especially, there is two categories. The first one is, as everybody knows, is the congenital malformations, and the other one is also a real social problem, the rheumatic valve disease. Let me start with the congenital malformation. Everybody knows that the incidence is fluctuating between 4 and 12 cases per 1,000 births alive, which represents between 12 and 36 million children with congenital malformation. And unfortunately, half of them will die of the consequences of their cardiac diseases, infection, malnutrition, and some of them will be inoperable. And for the other 50%, I believe there is something to offer. And as you see, this number is not a small number, is between 6 and 18 million children suffering, who are continuing to suffer from congenital malformations. And this one, there is another reality, that there is every year 130 million births in the world. And as we know, the incidence of congenital heart malformations, you can easily calculate that there is an additional amount of number between 500,000 and 1.5 million neonates born with congenital malformation, who will be added to this total number every year. Regarding the rheumatic valve disease, if you look at the statistics of the World Health Organization, the incidence is 0.5 per 1,000 children, and globally I can tell that 1% of children, especially in Africa, suffer from this disease. At least there is 12 million people across the world who are involved. 2 million children need repeat hospitalization, and unfortunately, again, based on the statistics of the World Health Organization, there is 500,000 deaths per year. And 1 million people, and especially children, need valve surgery. To make things a little bit more clear, I wanted, to show this one because if you have a population of 10 million, and if you would like really to start a humanitarian project, you have to know that there is 20,000 children suffering from congenital malformations and 5,000 children from rheumatic valve disease. It means there is, for a country, for a low-income country of 10 million inhabitants, there is 25% children who need cardiac surgery. For example, if you go to Vietnam, where our foundation has a program, you have to multiply this number with 10 because it's 100 million inhabitants. In Mozambique, where we have also a humanitarian program, 20 million inhabitants, it means there is 50,000 children who need cardiac surgery. Now the question will be, how to solve this problem and what is the ideal long-term tactical plan and model. And to summarize, because usually when I am presenting the humanitarian pediatric cardiology or all this humanitarian project, they are asking me if really the humanitarian project can be sustainable. I can tell you they can be sustainable if there is a very strong commitment from the side of all the actors, stakeholders involved in the project. Here above you have the NGO or the international organization. In the middle you have the project, and on the opposite side you have the host country. The mission, the essential mission of the NGO involved in a humanitarian project is to provide education and teaching, clinical and research support, and sometimes kind of administrative and logistical support, and a lot of financial support. I will say, endless financial support, and for a reason, you have to get financial partners to make the project sustainable in long term. But on the other hand, the host country has also, I will say, a lot of obligations because they have also to contribute to this financial aspect. They have, to provide political support. In the past, in some countries, I had also some project which failed, and then it was related to the lack of political support. And you have also to get also the contribution from the host country regarding the clinical and research support, present, the right candidates, the right human resources to be trained by the NGO or international organization. Now, regarding our humanitarian experience, which started in Geneva in '95, I started establishing a collaboration with the humanitarian NGO Terre des Hommes, and in '98 we started our humanitarian missions in Eritrea. And just, after the first mission, we founded the Humanitarian Association Cœur pour Tous in '98, which was later on integrated into Kalaγκos Foundation in 2014. Again, I would like to show some sustainable project. For example, in '98, we started in Georgia. Now the center is completely independent, and they continue to offer their services not only in Georgian children, but even in children coming from Armenia, from Azerbaijan, and so on. Again, 1999, Mozambique, we set up the Pediatric Cardiac Surgery Center, Instituto de Coração, in Maputo, in the capital city. It was a project which was realized by the close collaboration of 4 NGOs, including ORS. And the center also is completely independent now. Again, another successful project in Mauritius. We started in 2000, and we set up the cardiac center. And not only, they are offering their services in Mauritian children, but they are also on a yearly basis. They are receiving a lot of children coming from different islands of the Indian Ocean, Madagascar, and so on, Kenya, etc. In 2003, Serbia, after especially the bombardments of NATO, there was a difficult situation for the country. And during the spirit of time, we provided a lot of help. And finally, in 2003, we set up a good unit over there, which is highly functional now. And they trained also a lot of pediatric cardiologists and pediatric cardiac surgeons. And I can tell that they are able to treat surgically more than 90% of their local cases. Again, in 2005, another sustainable project in Vietnam, in Saigon, we signed a convention, a memorandum of understanding between the University of Ho Chi Minh and the University Hospital of Geneva. And in this project, we put also the Ministry of Health because we wanted to have also the political support from their side, and it was a very successful project. And now this university, this Department of Cardiac Surgery in University Hospital of Saigon performs on a yearly basis more than 1,500 surgeries per year. Again, another nice project in 2006 with Cameroon, especially thanks to the close collaboration with the foundation of Chantal Biya, the First Lady of the country. Again, another collaboration with the University Hospital of Geneva. And later on, again, a good project in 2017 in Yinchuan, China. Especially this project was, to improve a little bit the educational level in pediatric cardiac surgery at Carver Heart Center. And we signed a memorandum of understanding, and I continue to have a telemedicine program because there is now 2 very good surgeons covering the whole needs of this province. After having showed all this sustainable, beautiful projects, I would like also to pay tribute to the former Vice President of the United States, Mr. Al Gore, because thanks to the contribution of his foundation, he helped us to set up many programs, especially in South Asia. And I would like also to pay tribute to Bernard Kouchner, the founder of Médecins Sans Frontières, Nobel Prize, former Minister of Health and former Minister of Foreign Affairs of France, who help us to set up many projects in Africa. Now, regarding the humanitarian actions and projects, we are in 20 low and middle income countries, initially through Hearts for All and then Kalangos Foundation. There is more than 20,000 children who were treated since '98 by surgeons and teams trained by us in all these countries where we were involved. And especially, I would like to show you some of them from Georgia, Cameroon, Azerbaijan, Mauritius, Albania. As you see here, there was around 72 surgeons, pediatric surgeons, anesthesiologists, pediatric cardiologists who were trained thanks to the scholarships given by the Kalangos Foundation. In 2003, we started organizing the humanitarian forums in cardiology and cardiac surgery every 2 years. In collaboration with all international organizations, especially with the World Health Organization, the World Heart Federation. And this year in November, we will organize the 15th Global Humanitarian Forum in Bangalore, India. Again, we started in 2019 the edition of the Journal of Humanitarian Cardiovascular Medicine. Up to now, we received more than 40 articles, and the responsible, the editorial manager is Mrs. Futini Kirici, who is doing a wonderful job. I would like also to pay tribute to her. Last year in November, we reactivated the project of Global Heart Network. The Global Heart Network is a foundation, is an American foundation according to the federal law of United States. We founded it in 2011 in Delaware, and it was created to improve, especially the provision of cardiac care in middle and low-income countries. Between 2011 and 2016, we tried to develop the technology for organizational and program efficiency for all stakeholders working in the humanitarian field. But it was very difficult, and for that reason, you know, we started providing more heart care to children across the developing world, referring them to Geneva and other centers. But thanks to our recent collaboration with the Sri Sanjivani Foundation in 2024, we have started establishing this humanitarian platform to achieve our initial goals. If you have, you know, some interest, you can go, you have the website, you can, if you are a physician, you can register yourself, and you can check everything this platform is able to offer to the children across all the low-income countries. As I told you, know, there is this Global Heart Network, especially the platform we set up, has three essential missions. First, to connect independent efforts and initiatives coming out from different stakeholders with people in need via a collaborative platform. The second one is to improve the provision of pediatric cardiac care in middle and low-income countries. And the final one is to organize and coordinate all the humanitarian actions. You see, it's a very ambitious project, this one, between the different stakeholders. Who are the stakeholders? As you see, there are multiple NGOs, hospitals, networks, World Health Federation, humanitarian journals. There is the industry, because some of these companies, they have also foundations providing free of charge material to low-income countries. The national health authorities, especially the health ministries, the World Health Organization, the scientific societies, and there is also some kind of individual efforts coming out from some cardiologists and cardiac surgeons involved in sporadic humanitarian missions. Now, this one is what we achieved. We created a centralized structure of the platform. As I told you, there is 16 million children waiting for surgery in the developing world. And as you know, even in the rural areas now, you can easily find out a laptop. You can get access to internet. You can make an application for an overseas free of charge treatment. You can upload the heart carry course investigation imaging, and we receive all these things because we have a committee, a team made of cardiologists, pediatric cardiologists, and cardiac surgeons at the Global Heart Network, who screen all these medical files, reports, investigations, and they decide if the child is inoperable. We organize the treatment with the local medical and paramedical counterparts. If the child is operable, we transfer to the closest humanitarian cardiac center for surgery or treatment. One of the centers where we will be able, to refer those children will be the International Center of Humanitarian Medicine in Silivri, Istanbul. Again, this one is an ambitious project in collaboration with Divine Will Foundation from the United States. And all these efforts are focused on this 16 million children, especially waiting for a last hope, I will say. And I would like also to finish with this great American philosopher, Joseph Addison, who once told the grand essentials to happiness in this life is something to do, something to love, and something to hope for. Thank you so much.
Professor, thank you very much for your detailed speech. You are doing remarkable work. I would like to invite Mrs. Dr. Krupali from Fiji Island. Are you Fiji or Canada?
Fiji.
Hi. Fiji. Dr. Krupali is the director of Sai Sanjivani Children's Hospital in Fiji, who is they have a heart center there for children and for the children of Fiji and the South Pacific. We personally met last September. It's an honor to have met you. Hi. You want to comment on Mr. Kalangos?
Sure. Thank you so much for this invitation. Truly honored to be online today. Thank you, Professor Kalangos, for a wonderful presentation. And it's very close to my heart because you're talking about, pediatric cardiac surgery in developing countries. And I think from your presentation, it's very evident that there is a real need to assist the children in developing countries, and that the burden of congenital heart disease and rheumatic heart disease, especially in the developing world, is still very high. And there are many gaps. But it's really heartening to see all the work that is happening. So I congratulate you, Professor, for all your work with your Kalangos Foundation and now also with the Global Heart Network. And for me here in Fiji, so I'm the director of the Sri Sathya Sai Sanjeevani Children's Hospital. We had the pleasure of having Professor Kalangos and his team with us in September, and they operated on quite a few children with congenital heart disease and also rheumatic heart disease. Many of you may not really be aware, but till we built our hospital and it opened in 2022, we had no hospital in Fiji or the Pacific Islands that was able to assist these children. And we have at least 200 children born every year in Fiji and about 2,500 children born in the South Pacific Islands. Our hospital provides free surgeries. There is no billing counter, but we rely on the support and the generosity of many people and specialists and surgeons like Professor Kalangos from different parts of the world. So we do have visiting teams that come almost every second month. We've done about 351 free heart surgeries so far and over 25,000 echocardiograms. Our hospital was built also. So the government of Fiji granted the land to us. I work with Cyprema Foundation, and that's the NGO that I work with. However, it was a $25 million project, Fijian, which is about 13 million US dollars. And all of this had to be funded by us as a foundation. We worked with a lot of people from different parts of the world. But what I would say, Professor talked about, working the politics of it, working with the government and the Ministry of Health. And I think in Fiji, what we are doing as an NGO, we have built this hospital and we've equipped it. And we really kickstarted the project. But I'm happy that the government is now supporting us as well. They're providing us with a small grant. But more than that, when we have surgeries happening, we have the medical professionals, the doctors, nurses, and some medical professionals coming from the public hospital to work with our visiting team. And we as a hospital have also employed some of our own nurses, biomedical engineers. We're working on recruiting a cardiologist. And of course, we will look forward to training a perfusionist as well. And, it's only been 2 years. It'll be 3 years in April for our hospital. But a lot has happened. But we know that it's a very steep curve. We still really need to work on building local capacity. But I'm really happy that we have some nurses that we're already training. One of our nurses has gone to India for further training at one of the hospitals, the other Sanjeevani hospitals. So I think that the future is bright, although there's a lot more work that needs to happen. But many of our children who would have died, have had the hope and have had the opportunity to have surgery. So I'd say that it is possible. It's not easy. It is very challenging. But I'm really happy to say that, we have a center in Fiji that caters for not just Fiji, but also all the South Pacific Island countries. So thank you, Professor. And also thank you, Nicholas, for being a part of the mission that you were here. You operated on some children who are quite complicated. You gave them hope. And I think that really is important. And that's really what it is, isn't it? It's that hope. And, when you see these parents and you see these children after they've had their surgery, you can just see how happy they are. And many of our parents and our children here didn't have that hope. And because of our hospital and because of the work that's happening now in Fiji and the Pacific, I would say that it's been an incredible 2 years. We've had teams from Australia, New Zealand, the United States, from Singapore, from India, of course, from Greece and Turkey, from Professor Kalangos' team. And we very soon, just next week, we have surgery starting and we'll have the Singapore team coming. So Professor Kalangos, I congratulate you for all the work that you are doing. And I look forward to, seeing you again in our hospital. And I really hope, and I'm sure that this Global Heart Network is really going to change and transform the lives of millions of children around the world. So thank you very much for this opportunity.
Thank you very much for being with us. Thank you.
Thank you.
Thank you very much, Dr. Tabu. You are doing an amazing work there, and all the logistics there that you have. When I went there, it was everything was amazing. I couldn't believe like moving all the people, and you had all the disposables that available, many choices. That it's almost amazing the work that you do there. Okay, thank you.
What time is it in Fiji now? She didn't hear. Okay.
Should be. It's 7:23 in the morning. Okay. Thank you, Professor Kalagos.
Thank you so much, Nikos.
Thank you.